Patients with renal failure who have high serum phosphate levels often take drugs called phosphate binders. These will lower the serum phosphate level back towards the normal range. One of the reasons they do this is because long-standing untreated hyperphosphatemia can lead to a problem with the blood vessels diffusely throughout the body. This is called metastatic calcifications. It's also sometimes called calciphylaxis. This is only seen in chronic hyperphosphatemia among patients with chronic kidney disease. What happens is the high phosphate levels lead to phosphate being taken up by vascular smooth muscle, and then the blood vessels basically undergo a process of osteogenesis where they become more like bones. As a result, the vascular walls become calcified. This can lead to increased systolic blood pressure because there's less vascular compliance. It can also lead to thrombosis of small blood vessels, and this can lead to painful nodules and skin necrosis. And this is a picture on the screen of someone with calciphylaxis and necrosis of the skin from this process. Just like hyperphosphatemia is rare, hypophosphatemia is also a relatively uncommon disorder. When it does occur, the main acute symptom is weakness. You need phosphate to make ATP, so when you have hypophosphatemia, your ATP levels become diffusely depleted, and this will present as muscle weakness. Often it's respiratory muscle weakness, so in a patient who is in the right clinical scenario for low phosphate levels, if that patient develops respiratory difficulty, one thing you need to consider is that they may have low phosphate levels. Chronic hypophosphatemia over time leads to bone loss and osteomalacia. This is usually not seen in the modern era. I've listed some select causes of hypophosphatemia on the slide. First of all, primary hyperparathyroidism reduces phosphate levels. The next two causes I've bolded because they're very high yield for you to remember. Diabetic ketoacidosis, or DKA, classically leads to hypophosphatemia. That's because glucose induces a diuresis and you lose phosphate in the urine. In addition, alcoholics who have poor nutrition and are admitted to the hospital can develop what's known as the refeeding syndrome. So alcoholics have chronically low phosphate levels from poor nutrition, and when they start to eat food, their metabolism ramps up and this further decreases the phosphate level. So in either an alcoholic or a person with DKA, if you see a description of hypoventilation and respiratory muscle weakness, one thing you should think of is that there may be a low phosphate level. Hypophosphatemia has also been reported among patients taking certain antacids that bind phosphate. The classic one to do this is ammonium hydroxide. And then patients who have the Fanconi syndrome have wasting of phosphate in the urine, and this can lead to hypophosphatemia. I'll finish this video by talking about magnesium. This is the most confusing electrolyte, and the reason is because magnesium levels can alter the levels of calcium and potassium. For this reason, magnesium disorders often go together with disorders of other electrolytes. We'll start by talking about hypermagnesemia. To understand the signs and symptoms of increased magnesium levels, you need to appreciate that magnesium can block calcium and potassium channels. For this reason, many of the effects of a high magnesium level are similar to the effects of low levels of calcium or potassium. So for example, patients with hypermagnesemia often have neuromuscular toxicity. This presents as decreased reflexes and weakness that can progress to paralysis. They also have cardiac dysfunction. Things like bradycardia and hypotension and even cardiac arrest can occur. And then finally, hypermagnesemia can cause hypocalcemia, and this is because magnesium can inhibit parathyroid release. In the video in the endocrine section on the parathyroid gland, I talk about how high levels of magnesium can shut down parathyroid hormone release, and this can lead to hypocalcemia. There's really only one important cause of hypermagnesemia, that's renal insufficiency. When your kidneys don't work, you can't excrete magnesium, and this can lead to hypermagnesemia. Patients with hypomagnesemia also have neuromuscular problems, but in this case it's excitability, very similar to what we described before with low calcium levels. Patients with low magnesium levels can have tetany and also tremor. They can also have a number of cardiac arrhythmias. But the two very high yield effects of hypomagnesemia that you always want to remember for board exams are hypocalcemia and hypokalemia. So let's talk about how low magnesium leads to these two problems now. The effect of a low magnesium level on the parathyroid gland depends on whether the level is a little bit low or very low. If there is a slight reduction in the serum magnesium level, this can stimulate parathyroid hormone release, just like hypocalcemia does. The reason this happens is because parathyroid hormone, in addition to raising calcium levels, can increase GI and renal magnesium reabsorption to raise magnesium levels. So basically, a small reduction in the mag level leads to more PTH release to bring the magnesium level back up to normal. If, however, you have a severe case of hypomagnesemia, this will inhibit parathyroid hormone release. This is the opposite effect of low magnesium. The reason this occurs is because some magnesium is required for normal functioning of the calcium receptor in the parathyroid gland. I talk about this in more detail in the endocrine video on the parathyroid gland. When this happens, there's abnormal function of this calcium receptor, and that leads to suppression of parathyroid hormone release. So for this reason, hypocalcemia is often seen in severe cases of hypomagnesemia, and it is very high yield to remember this. Patients with hypomagnesemia also classically develop hypokalemia. And the reason for this is because magnesium inhibits potassium excretion under normal circumstances. In the kidney, there is a potassium channel called ROMK. This stands for the renal outer medullary potassium channel, and it's found in the cortical collecting duct. So let's look at the bottom of the screen. Here's a cell in the cortical collecting duct, and here's this ROMK channel, which can allow potassium to go out in the urine. However, this channel is inhibited by magnesium. When you develop hypomagnesemia, this channel basically goes nuts and starts releasing lots of potassium into the urine. For that reason, patients with hypomagnesemia develop hypokalemia. And in addition, you cannot correct the potassium until the MAG is corrected, because you need to correct the MAG to shut down this channel. So a classic clinical scenario is a patient with hypokalemia and the potassium is being repleted for several days but will not normalize. That patient probably has hypomagnesemia, and you have to fix the magnesium level before you can correct the potassium level. Some selected causes of hypomagnesemia are shown on this slide. GI secretions contain magnesium, so patients with diarrhea can develop hypomagnesemia. Pancreatitis can lead to a number of electrolyte abnormalities. Treating patients with pancreatitis involves close monitoring of the electrolytes. One of the reasons for this is that in pancreatitis there's a process called saponification that occurs, where magnesium and calcium collect in necrotic fat. There are a number of ways you can lose magnesium in the urine through the kidneys. Loop and thiazide diuretics can cause hypomagnesemia, and alcohol abuse is an interesting cause of hypomagnesemia. Alcohol has been shown to cause tubular dysfunction in the kidneys and lead to hypomagnesemia, and alcoholics who present to emergency rooms classically have hypomagnesemia, and that's worth remembering for your boards. And then there are a number of drugs which can cause hypomagnesemia. One of the famous ones is omeprazole, which is a proton pump inhibitor. It's been associated with impaired absorption of magnesium from the GI tract. And another one is Foscarnet, which is an antiviral drug. So let's talk about this now. In the infectious disease section in the video on antiviral drugs, I talk about Foscarnet. It's an antiviral pyrophosphate analog. This is its structure down here on the screen. It looks a lot like phosphate, and it works by binding and inhibiting viral DNA polymerase, and it's used in treating a number of viral infections, including CMV. Some of its side effects include nephrotoxicity. This is the limiting side effect, and also seizures. But in addition, you should know that this drug is famous for causing every electrolyte abnormality you can think of. All of these abnormalities I've shown on the screen have been described in patients on Foscarnet. You're never going to remember all these, but if you see a description of a patient with a number of electrolyte abnormalities, and this drug is one of the answer choices, you should think that that may be the correct answer. And that concludes our video on electrolytes.